Well, welcome everybody. Before we get started here, just our first order of business. We have a lost cell phone that was left in the men's room on the main floor of the med school. So it's just sitting on the desk up in front for somebody to come claim that. Really pleased to welcome our speaker today, Dr. Nate Miller. Many of you know Nate well, as I do, from really his years of service. And coming through training at University of South Dakota. Nate was a medical student with us. He was a resident with us, won a number of awards during both medical school and residency, and then really has fulfilled a lot of really key jobs for the school throughout really his tenure as a hospitalist in Vera for the last 10 plus years now. He's currently a chief of the Division of Hospital Medicine for the School of Medicine. He's also the clinical vice president of the hospitalist service line at Avera. And today he's going to talk to us about the medical management of stroke. So welcome, Nate. Thanks for coming.
Well, thank you for having me. So we're going to talk about stroke today, specific ischemic stroke. So I think most recent data says ischemic stroke is 87%. Hemorrhagic stroke, 13% of the population that we see. Now, a good friend of mine, Dr. Joe Rees, who I did residency with, told me it's always good for keys to a successful marriage is under promise and over deliver. And so we're going to hopefully do that with this lecture here too. So disclosures. One, I have no affiliations with any companies. Two, I'm an internist, not a neurologist. So we'll get that out of the way right away. And I won't pretend to be a neurologist, but I do think internal medicine physicians, primary care physicians, APPs have a role to play in management of stroke patients so that we can better utilize effectively our subspecialists. 4% of IM boards is devoted to neurology. And coincidentally, that was also the first rotation I was on as a hospitalist at Avera, as they put me on 2 West. And I still remember being like, really? This lecture, and I want to be very clear that this is not for physicians working at comprehensive stroke centers or physicians working at thrombectomy capable centers. These are for physicians, APPs, hopefully residents learn something, med students as well, on the bare bones of stroke care. And that's not to undersell it because it's critically important. Another disclosure, as a hospitalist and head of or coordinator of the service line, we are under discussions with neurology to enhance stroke program care for rural and regional hospital clinics. Ensure patients get the right care, right place, right time, right location. So again, more so, why ischemic stroke specifically? So we all know this. Beds at tertiary and quaternary centers are a precious commodity. So Mayo, U of M, UNMC, we all know when we have those rare patients we want to transfer, it takes time, right? We all know if you're in South Dakota, Minnesota, Nebraska, North Dakota, Brookings, Gregory, it is, sometimes your patients are waiting to come down, whether it's to Sioux Falls or whether it's to Rapid. And how do we create a system that provides support, one, while you're waiting, two, also, if there are some patients that our primary care physicians and our hospitalists and our APPs can assist with, let's empower them to do that without being a wall saying you can't come to Sioux Falls or Rapid. So critical access hospitals are often tasked with initial management of ischemic strokes. And that's where they're going to hit a lot of places right away, particularly anywhere outside of Sioux Falls, Rapid. Obviously, for most people, anything 10,000 or smaller is very small. For me, anything 10,000 or bigger is pretty darn big growing up in a town of 1,000 people. But that's a lot of our critical access hospitals are less than 1,000 people. So we have to remember that too. 3, we talk hub and spoke model. And you can apply this to stroke, you can apply this to really any clinical condition. So you have your tertiary quaternary centers of care, right? And you have everything, regional hospitals, critical access hospitals, clinics. I think the key we all need to remember is neither is more important than the other, because it's all about patient care, right? And how do we get patients the right care when they need it? Resource utilization is key. It's key now, likely will be more key in the future. Some of the challenges we're up against is, less nursing homes, extending length of stay, population growth, people are getting sicker, all those things. And so how do we help? So again, it's important, let's level set, target audience. So it's critical access physicians, APPs, med students, residents, and general internists, family medicine who are non-neurologists. That's really our population we're targeting this talk to. I'm an internist. So if you are 17 years and 364 days, you should be on another service in my mind. So this only involves around 18 or above. And so specifically, we're talking about ischemic stroke. I want to talk about what type of ischemic stroke patient we're talking about, or what we're not talking about. So the patients who have a large vessel obstruction, who've received TPA, who needs to be at a thrombectomy capable center, that is not this patient population. We're going to assume the patients we've talked about already, they've had their CT of the head, it's negative for bleeding. They've had their CTA, it's negative for large vessel occlusion. Maybe they've had a CT perfusion test because it's greater than 6 hours, see if there's an area of ischemia that they can salvage. They don't have any of those things. Now, those are actually the majority of patients. So we're talking about a smaller subset too. Med surge. So look at med surge from a Sioux Falls standpoint, I would say. It's not your step down unit. It's not people in your neurocritical care units. We're talking about med surge level. And we're really focused on the time frame. The first 24 to 48 hours is going to be the focus, with the caveat. We'll talk about a few other things of how do you set the patient up for success if we don't necessarily know the why, meaning why did they have stroke? So let's talk about initial treatment. We're specifically going to talk about non-cardioembolic stroke here initially. We're going to focus on the antiplatelet, anticoagulation treatment first. So CT at first thing, that patient's coming in, there's CT of the head. We know it's negative for bleeding. We know they're not LVO. We know they don't receive TPA. They get aspirin, right? So aspirin, 4 chewable, 81 milligrams, or if you can't chew, there's always a 300 milligram suppository as an option too, because you have good absorption within the rectum. We're also talking about for dual antiplatelet therapy. This is non-cardioembolic without evidence of moderate to severe symptomatic extracranial stenosis. So they're not a candidate for a stent. They're not a candidate to go on Eliquis. They're not a candidate for carotid endarterectomy. And we'll get into some of the data behind this because I think it's always good to talk about the why when we talk about them too. So dual antiplatelet therapy candidates. So guidelines. And that's what we'll hopefully stick fairly close to, and I'm hoping you'll hold me honest if I deviate, because I should know that, or when I deviate. National Institute of Health Stroke Severity Scale, or NIHSS. So that's a score nursing physicians, they take as soon as that patient arrives, right? Score less than or equal to 3. So that's someone who has defined ischemic stroke. So that's a low risk stroke, 3 or less. There are some studies that look at 5 or less. This one is sticking to in a perfect world that does not exist. It's easy to figure out that there's this 3 or less right away. Or TIA. So transient ischemic attack, an ABCD2 score greater than or equal 4. Now, I'll freely admit I'm not a super fan of scores, but that's what the guidelines base it on. So that's what we'll be talking about. And that's a a scoring mechanism to say how high a risk is this patient with. For the higher 0 to 7, the higher you go, the more likely you're going to have a stroke further down the road. Well, those patients, they should be loaded on Plavix, 300 milligrams. So this is after they've already received their full dose aspirin, of course. And once they've done that, then following that, day after, day 2, let's say, no evidence of bleeding, Plavix 75 milligrams daily. Data shows 90 days. Aspirin, now the study showed 75 milligrams. We use 81, right? So we use that equivalent. So 81 milligrams, and that is for 21 days. So Plavix, and they actually stop the aspirin. A lot of times we'll stop the Plavix and go to the aspirin, and that can be a different discussion. But for this study, aspirin for 21 days. So where's the data based off? So this is one of the first ones, a dual antiplatelet therapy. And I do not have any tie to New England Journal of Medicine, but almost all these slides are from there. So, because they do a really good job also of making it easy. So, from 2013, clopidogrel with aspirin in acute minor stroke or TIA, CHANCE trial. So the CHANCE trial is a trial that's conducted at 114 sites. We'll go back, 114 sites, 5,170 patients total. Now, one of the caveats, it was not a very diverse patient population. 98% of the patients were in China. So we always have to ask, can we apply it to the people we see, right? So in that study, 72% of the patients had low-risk stroke as defined by the NIH-SS score. 28% had TIAs. So they had the treatment arm. So the comparison arm had Plavix, loaded Plavix, got their aspirin, and then they went ahead and got Plavix for 75 milligrams for 90 days, aspirin 75 milligrams for 21 days. And then they said, looked at outcomes. And for outcomes for this was fatal or non-fatal stroke was the outcome for these measures. And so here's what we have. And what you can see, nope, that is not how you use that. There we go. I'm sure no one on the screen can see this, but top arm that's red, that's the treatment group, clopidogrel and aspirin. Compared to aspirin, that's what we're comparing it to. So what you'll see is there is actually a statistically significant difference in the numbers of non-fatal stroke and fatal stroke over the course of time. The interesting thing, and this will come into play later, is right here, most of the benefit is within the first 24 to 48 hours, and it really stabilizes. I think that's important, and people smarter than me also think that's important, because that's what we know about stroke, right, and TIA. The first 24 to 48 hours, that is when you're at highest risk, and it's still the risk goes out, but it gets markedly less as we get farther away from that incident event. In addition to this, so the absolute difference, that's important to state, the absolute difference, 11.7 in the non-treatment group and 8.2%, so 3% difference. That's significant, but again, does it apply to our patient population, right? Number needed to treat, 29 patients. That's a pretty good number needed to treat. You can make an impact fairly quickly for fairly inexpensive medications as well. That's part of all this too, is it doesn't matter if the medication's phenomenal. If I, as a patient, can't pay for it, it's still not going to help me, right? So I think that's something important too, that we don't get out of the studies. So let's go to the next study. So then we said, okay, we have this, but what about different patient populations? So fast forward to 2018, the clopidogrel and aspirin in acute ischemic stroke and high-risk TIA. So this is the POINT trial. So we had the CHANCE, now we have the POINT trial, which for me is a lot easier to remember than the actual title. And so this one actually looked at a broader patient population. So I'll go back to that again. So this one randomized, similar metrics, ABCD score 2 or greater, 4 or greater, NIHSS score less than 3 or equal to. So low risk stroke, high risk TIA. This outcome was major cardiovascular events. So this one was stroke, MI, death at 90 days were the predominant ones. Now, there are a few caveats with this. They stopped randomization at 84% because they ran out of funding. They did, or excuse me, this one they stopped randomization at 84%, not because they ran out of funding, but because they actually reached both the efficacy and safety endpoints. So they didn't complete it, but they reached both the endpoints. And so 4,801 patients over 269 sites across the world, although 82% of the patients were in the US. So what did they find? So top, and a few other caveats. So the top arm is the patients with an event, right? So you have aspirin, will have more likely clopidogrel plus aspirin. A few differences is in the way they dose this though. So this is aspirin similar, and they gave variants, could be 81 up to, I think, 325. This is where it differed fairly significantly, and this will come into play. Clopidogrel plus aspirin. So loading dose was a little more, 600 milligrams of clopidogrel. Continued 75 milligrams through the 90 days. Got their aspirin. A big difference is that at day 21, they continued aspirin. So they continued it through 90 days. Now, because what you'll see down below here, how surprising, you're on multiple agents for an extended period of time, you have an increased risk of bleeding. And this specifically was major hemorrhage. So that includes GI bleeding, that includes intracranial bleeding, all the above. So how do we make sense of this? Or how do the experts make sense of this? And then also, how did we get to the guidelines that say 21 days? Well, so this patient population, right? So let's talk about this. So now we have a more diverse, probably not diverse enough by any means, but more diverse patient population that we can say, hey, this might apply to our patients. And two, the theory is, you see that first 48 hours is when we're within the greatest risk of having a stroke. That risk really decreases after probably about day 28. The risk of bleeding really starts increasing about day 8 or 9 and extends through day 90. So that's where the experts came up, a lot smarter than myself, came up with the guidelines for the 21 days. Now, some interesting things, I think. The one, we talked about the different, 98% Asian, the other one, this one, predominant Caucasian, African-American, 3% Asian. Additionally, I think what's interesting too is the difference in percentage of stroke. So if you think back, the percentage of patients who had TIA in our previous study was only 28%. This one is 43%. What does that mean? I don't know, but it's different. So I think it's important that we call that out. And again, that is definitely where I would go to a neurologist and say, what do you think? And probably will next week too. So, and so here's the study from, this is the going back to the CHANCE study and showing that percentage difference. The other thing that I think was interesting and going back again is just looking at what you can't see on here is BMI in this study is 25. And so I'd love, and that's the CHANCE study in Asia. I'd love to say that's our average BMI, but I don't think that's very typical of the population we see. So we have to take that within context too. Regardless, guidelines right now, dual antiplatelet therapy, non-cardioembolic, non-severe carotid artery stenosis, load of 300 Plavix, 75 daily, aspirin, and then aspirin 81 milligrams for 21 days. And I would argue go to aspirin as opposed to Plavix just because of less risk of bleeding, but our data doesn't say that. So that's where you have to decide. So I say to everyone we work with, med students, residents, life would be easier if it was A, B, C, or D. Unfortunately, as you learn, it's not. So let's talk about, and I admit I struggled a little bit. Should I even talk about this? Because these aren't patients that you're going to fix their issue at a critical access hospital, and most regional hospitals you're not going to either. You're going to have to be a tertiary or quaternary center. But still, you're managing these patients. We're managing these patients. And so we're also, our most important job of primary care physicians is we're a safety net too. So things happen. We're human. So if something doesn't stick out, then we can catch it and help. So large extracranial arterial thrombosis. So fancy term of saying carotid artery stenosis. That should be stenosis, not thrombosis. And symptomatic. So you have a stroke, it's on your right side. Your carotid artery is for sure greater than 71 to 99%, or 50 to 69 is an option too. You give them aspirin, and then the data shows we should be considering revascularizing patients. So that should be a referral to your neuroendovascular specialist, vascular specialist, and they will make the decision, which we will not get into. Is it carotid enterectomy versus carotid stent? So this is another one similar. I struggled, should we even talk about these? Because most of these probably should be coming if within the time frame to a place with capable of thrombectomy, because cardioembolic usually lead to large vessel occlusions, right? But I think it's still important to talk about the aftercare. So let's pretend they had a large vessel occlusion. They came successfully to a center that did the thrombectomy, pulled the clot out. They may or may not have gotten TPA. Now they come back to you and things slip through the hospitalist cracks, and I did not discharge them on anticoagulation. So was that the right thing? That's where handoffs are real critical. So CHADS-2 VASC score, risk stratification, right? Greater than 1 men, greater than 2 women. It says we should do oral contraindication, less compelling indications to indicate otherwise. Now, a lot of this is based off multiple different studies. The one I always refer back to is that Aristotle study. There's the Rocket AFib study, I think, as well, which was Xarelto. So a lot of times we're using these meds back and forth depending on what insurance covers, because they're very expensive if insurance does not. So in that end of 3436 showed a decreased incidence of the recurrent risk of stroke or systemic embolism. It also showed a decreased risk of bleeding. And one thing that differs with the Aristotle study is the decreased incidence of recurrent stroke and systemic embolism. That was statistically significant, where some of the others were more driven by the decreased risk of bleeding. And so that's why we've gone away from predominantly, except when it's absolutely indicated, mechanical valves being one of the number ones for warfarin. Now, we still put patients on warfarin if they can't afford Eliquis or Xarelto, rivaroxaban, apixaban. Try to stay away from brand names. So, because again, if you can't afford it, you're not taking it. It's not going to do you good. So let's talk about something near and dear to my heart, especially if you've been on the teaching service. Not necessarily stroke management and blood pressure, but just blood pressure management in general. We could have a whole lecture on this, probably boring lecture, if we did it on hospital management of blood pressure, right? We do a lot more harm by treating it too aggressively and really probably messing up what the primary care physicians did before they came in. And so this one we're specifically going to talk about ischemic stroke and blood pressure management. So greater than 60% of patients with ischemic stroke have higher blood pressure immediately post-stroke. Part of it is autoregulation. We'll pull up that hideous autoregulation curve after this. The other part is, you know, you're narrowed, you have compensatory vasodilatation. You're trying to get to that area of ischemic penumbra, so brain at risk, so blood pressure is driving higher. And so everyone's inclination, especially if you're not used to taking care of patients like this, is when you see a blood pressure of 190 over 95, you're going to treat it. This instance, with exceptions, of course, if you think that it's high likelihood they have a stroke, I would encourage you not to. And the reason is they need that blood flow. And dropping it aggressively the first 24 to 40 hours, and really the number that we're beholden to is 220 over 120 at our comprehensive stroke centers. It can worsen the stroke. Now, it can also worsen other things, acute kidney injury, but the biggest, most devastating thing is it can worsen and extend the stroke because it needs that blood. There's an area of brain tissue that it's gone, but there's still an area of brain tissue that is at risk. And that blood is being driven to that area at risk. And we won't go into this in great detail. If you remember any of this from physiology days, so autoregulation, right? And so normal autoregulation, normal tensive, no vascular disease is on the left, the red. Most of these patients who come in addition to having higher blood pressure driven by the need to get blood flow, they automatically have higher blood pressure before because that's a risk factor. Look at how high the map is right here. And if we drop that, look how much quickly it drops. And that will drop a map, affects cerebral perfusion and blood flow, increasing risk of stroke, progressing in stroke. So dyslipidemia, you obviously have to talk about lipids, right? Huge risk factor. A little controversial on what actually does or doesn't decrease the risk, but we know we have data that says, is it the LDL target? Is it the anti-inflammatory effects? Is there something else? But we know there's data that we do have data that says it works. So this is a study from, let's see, this is a study from 2020, I think, if I remember correctly. And so this is the target to treat stroke population. So previously, the first time we ever had evidence, good evidence, that lipids worked was, I think it's called the Sparkle study, I think in 2006. They didn't know, they knew they worked, anti-lipid agents worked. They knew it worked, statins worked, they just didn't know to what LDL. There's debate, and there's still debate. But this study here specifically looked at patients who are on high-dose statin. They targeted a goal of 100 versus 70, right? And so if you look at it, age that fits for us, 66, 67 years of age, predominance of males population. Risk factors are fairly consistent across the board with what we see. And then they said, okay, well, is there a difference? And so this is what they found. So top here is actually, graph is our lipid levels. So the higher target group, obviously they're gonna have higher lipid levels. It just shows that there's statistical significance between red, lower lipid levels. And then what you see down here is difference in outcomes. Statistically significant improved outcomes in patients with 70. Now, a goal of 70 or less versus 100. Now, I think we should look through this. And when you look at this, it's good to go through the data. So major adverse cardiovascular event, right? 10.9 versus 8.5, statistically significant. Higher versus, or excuse me, lower versus higher group. So less major adverse cardiovascular events. Now, I think it's important if you go down to intracranial hemorrhage, there is major intracranial hemorrhage and major bleeding, there is a higher incidence of intracranial hemorrhage in this. Now, it is statistically significant as well. So how do we, so I think this study, I think we have to take it, my opinion, is you have to take it cautiously that it might do a good job of getting it down to 70. But there is a risk of bleeding. There also is this study as well. This one was the one that was stopped early because it ran out of funding. The other thing that kind of stuck out to me when I read through it was they didn't have a data safety monitoring arm because they didn't think dropping things too low, LDL too low, would have adverse effects. When we know that even before all this, there's talk about does it drop too low. So I bring this up with a hesitant of caution, is that I still don't know. Now, it's easy for me to say because neither do the guidelines. So that's a take home is maybe 70, but maybe not. So this is one of my favorite parts of this is imaging and monitoring modalities. So we'll talk first about CTA, and we'll save an echo and save MRI and cardiac monitoring for after. So CTA, that's where we're looking for carotid stenosis. Obviously, we've already looked to see if they have a large vessel occlusion. Let's talk about echo. And this will be controversial, I know. That's okay. Not everyone needs an echo with a bubble immediately. And I emphasize that really to the residents who, and I'm not faulting people for doing that either, but to the residents and med students who see that on every single stroke patient, right? Because where the data is, where you need the echo, patients less than 60. I would argue if you have a cryptogenic stroke and you don't know why, I'd probably get an echo with a bubble study. But you don't have to have an echo. And even more importantly, probably don't have to have one emergently. You don't have to have one urgently. You probably can wait a week. Get it. One fear is always, is there a large vessel thrombus? Usually we have other things that are pointing that they're at risk for that. They're in heart failure. Number of percent of strokes caused by large vessel thrombotic, so you have an akinetic LV, is actually 1 to 2% strokes. And so now MRIs. Let's go to MRIs. The studies of which TPA are based off of, they didn't even use MRIs, actually. And the reason I say that is there's MRIs. I'm not saying go and say we don't need an MRI on this patient. That's not what I'm saying. MRI is a great test. But how do you use it appropriately? And also when MRI is not an option for you, which outside of Sioux Falls Rapid, it is not an option 24/7 to my knowledge really anywhere. There are very few instances that you need one urgently or emergently. I think you could argue, do you even need it? But I don't think we'll ever get away from that. I mean, I'd be the same. If as a non-neurologist, I'd probably still go ahead and get the MRI eventually. But it doesn't impact outcomes. And that's why we do things, right? Now, there are instances when you don't know. So let's say one instance where you absolutely have to do an MRI is wake-up stroke. You don't know their last known well because there's studies to show that, hey, this patient may still be a thrombectomy candidate, MRI with MRA. Are you trying to decide, is this a stroke or am I more worried there's an intracranial lesion? Is there hippocampal sclerosis causing seizures? So there's still definitely, my takeaway for this, hopefully for people here, is you do not have to order MRI right away. And I would advocate that if your concern is needing that MRI, you have time to get it as well. Cardiac monitoring. So I brought this up because there's been a really recent study that came out that might change things. And so we know, what did we know before a month ago? You need cryptogenic stroke and stroke in general, we need to monitor the heart. They're on telemetry in the hospital. I think we learned probably 10 years ago, maybe more now, the crystal AFib study, that cryptogenic AFib, we'll call it. So you have AFib, you don't have symptoms. We're catching it because we're doing extended cardiac monitoring, whether it's loop recorders, whether it's Holter monitors or brand name Zeo patch that you stick on your chest and send people home with. they have an increased risk of stroke. What we don't know is how long is too long to be an AFib, and does anticoagulating actually have any improvement in outcomes? And so now came out a study with the New England Journal of Medicine on cryptogenic stroke, and it came out on November 12th of 2023. And honestly, literally right after I gave this lecture to CFM, like the day after. And they talked about subclinical AFib. So I think it's important to say, what is subclinical AFib? People, they don't know they have AFib. That's the best way to put it. We find it, right? The cardiac monitor. You could argue we find subclinical AFib in the hospital all the time, right? And our immediate gut is fine too, put on anticoagulation. So, and the anticoagulation and subclinical atrial fibrillation, it's controversial. So this is the article, very good article, Eliquis for Stroke Prevention and Subclinical AFib, published in November of 2023. I think it's only been online though. I don't think it's been in the actual journal itself. And so let's talk about the patients that they looked at. So I'll admit I like the age range here because this seems more in line with the patients I see in the hospital. 76. So greatest risk factor for AFib is age. Now, despite the CHADS-2 VAS score, still the greatest risk factor is age. You see the percentage of females there. You see their CHADS-2 VAS score, and so CHADS-2 VAS score is around 4. So they're at higher risk. And what they did is they took patients who were on aspirin, baby aspirin daily, and versus BID Eliquis. They stratified the people of AFib, and the AFib population duration was greater than 6 minutes, up to 24 hours. And there's different percentages, with the majority of the percentage of people with AFib in the range of probably 6 minutes to 12 hours predominantly. If they got greater than 24 hours, they said, we're pulling you out of the study and we're putting you on Eliquis. Because they called that at that point in time for their definition indication. And so what it showed is a reduced incidence stroke in those patients. Statistically significant. I think it was about a 1 to 2% decrease, absolute decrease, if I remember correctly. Now, it showed that, but it also did show an increased risk of bleeding, major bleeding. So major bleeding, fatal bleeding, symptomatic intracranial hemorrhage, gastrointestinal bleeding, transfusion performed. Statistically significant increased risk of major bleeding. Makes sense, right? So what does this mean? My guess is the verdict's still out. Now, one thing, and again, it's not within guidelines, but I think it'll be good to discuss with your attendings, particularly neurology, cardiology, what they're thinking of doing with this. So those subspecialists. And the interesting that major bleeding, so we have fatal bleeding, thankfully not statistically significant. Symptomatic intracranial hemorrhage, not statistically significant, but small numbers. What drove it was predominantly was everything combined. So the take home is there is an increased risk of bleeding, but it does also decrease the risk of stroke. And predominance of it actually was in GI bleeding when you look at it. Now you can say debility. This is, everyone's different. So the individual patient, debility, for me, debility, I'd rather have a GI bleed than a stroke and be, but that's easy for me to say, it's not me. So key takeaways. One, in non-LVO, non-TPA, non-cardioembolic, and people who do not have symptomatic carotid artery stenosis, consider dual antiplatelet therapy. Load them with Plavix, treat them with Plavix, 75 milligrams a day, and aspirin 81 milligrams daily. Aspirin, dual antiplatelet for 21 days. 2, MRI is not needed emergently. It's controversial if it's needed at all. But I bet if you poll people, 90%, including myself, would still end up getting an MRI. Just how soon do we need it? Do we need to escalate levels of care based off of the MRI? Echocardiograms are not necessary on all patients with stroke. Again, this is not for comprehensive stroke centers that are beholden to Joint Commission requirements. This is really, what do I need to do to take care of my patient when I don't have everything? What eventually maybe I'll do. There may be an indication for anticoagulation subclinical AFib as well. But I think before I finish, and those are my references, but I think one thing I think we all know is beds are a premium, right? Unfortunately, in our tertiary care centers. They are in South Dakota, they are in Minnesota, they are in North Dakota, they are in Iowa. No one wants it to be that way. But how do we leverage the system to improve care for the patient? No facility is more important. Whether you're a critical access hospital, whether you're a clinic, whether you're tertiary, quaternary, whether you're a regional hospital, everyone has a role in helping take care of these patients. So what I would encourage everyone is to think about what is your specific role and realize that we're all a team. It's not Sioux Falls versus Gregory, Rapid versus O'Neill, Bismarck versus Aberdeen. It's all about patient care. So let's remember that none of us know what it's like in the other environment. I have no clue what it's like to work in Brookings because I've never done that. I don't know what options are available. I would say the flip side is if you don't work in a tertiary care facility, you also don't know that aspect either as well. And so remember that we're all in this together to take care of patients and that together we will figure it out. I guess I want to open up to questions. Any questions in the room? Yeah, Eric.
EIAs or strokes, or is this, or are they talking about it in a little different setting?
Good point. Yeah, these are people. Yes, thank you for bringing that up. Yes, those are people who have a previous history of stroke as well. So this isn't patients. This is for secondary prevention, not primary. Thank you. Yeah, very good question.
In those Plavix studies, I don't remember, but do they exclude people for their pharmacogenetics, like if they were a metabolizer or like
Great question.
Yeah,
Great question. I specifically looked at that. I figured Russ would ask that question, which is reasonable, Dr. Wilkie. They didn't. Now, we can get to the one that I want here. This, I believe, is the Chance 2 study. Yeah. Yeah, this is the Chance 2 study, which actually compared clopidogrel, aspirin, ticagrelor, aspirin. Sure, I'm telling you the right one because I didn't look at this as much. And so the Chance 2 study really asked that question.
Oh yeah, I see it.
And what it did say essentially, they found statistical significance in like the theory, and specifically look at site 1, 2, site 17 variants, and then 1, 2, and 19 alleles. And this one showed, because all the other studies, they did not. This one, Chance 2, showed that if you had a variant, you were more likely to have a stroke on clopidogrel versus not. So that's where they advocate for the FEN. And so, along with aspirin. However, again, this was in 98% Asian population, so which has actually also a lot higher likelihood, one in, I think it's 60% of having one of those alleles, whereas the United States is 1 in 4. So it's another tool in our pocket. Now I'll admit, Dr. Larson and I, many years ago, we had a point counterpoint on should we screen everybody for this allele? Reading this pushed me more towards Dr. Larson's argument, so that we should. And so, but More to come. So we still don't know. And in the stroke guidelines, they don't advocate. Now, is that right? I don't know, how do you apply to the individual patients? Is any questions from those of you not in the room? Okay, thanks, everybody.